Start. Yes, of course, Democritus. We all know this. Some pictures, some nice, to make it a little more attractive, that's all. Why is it a little difficult to follow? Can you enlarge the size or something? Is it that or the size? Next one. It's a little... You can't enlarge the size? All right, but anyway, this does not require much elaboration. This team knows everything. It's more for completion's sake. Next slide, please. This is some of the accomplishments, some failings in the Millennium Development Goals. Again, everybody here is familiar. Next one. Some improvement in underweight and children and stunting of growth in each one from 90. Go back. From 90 to 93 to current date. In each one, the left bar is underweight children. Right one is the stunting of growth. Next one, please. While we are all familiar, I think it would be worthwhile to spend a half minute on this. If you see on the x-axis, GDP per capita in purchasing power terms. And the y-axis is the infant mortality rate. One indicator, obviously, we all recognize this, one of the perhaps sensitive indicators indicating to us the state of health in the country. The tendency all over the world is as per capita income grows, the IMR comes down. And we have taken only the emerging economies and poorer countries, not the richer countries. You can see India is an actual outlier. Our health indicators, even in terms of relative to our poverty level or income level, are simply appallingly bad. We are absolutely the worst. You can see that if you see both the income X and Y axis both. Obviously not acceptable. I think somebody in government must really start understanding this. Philippines, Vietnam, in Kyrgyzstan, Nepal, Bangladesh. I keep telling people about Kyrgyzstan because in education, they are slightly worse than us in the PISA outcomes. So even Kyrgyzstan is doing better in terms of, I mean, at least it's not good, but they're a poor country, much lower income, per capita income, etc. Next one, please. Next slide. Okay, this is hard to read. Just the big picture, 1.2 million children under 5, they die in a year. 2015 number is 1.2 million children. 9.7 million people. Can you read that? With a microphone.
Total annual cases of 9.7 million malarial infections, 2.5 million new cases of tuberculosis in 2015. Out-of-pocket expenditure for health forces 63 million people below the poverty line.
This number, even in this presentation, we used a number varying from 55 million to 63 million. Each source is giving a different number. But they're roughly comparable numbers. Therefore, please do not hold us to ransom or to account on the specificity of the number. But something like 50, 60 million people falling below poverty on account of expenditure related to ill health or on account of ill health and therefore reduced income. I think that's the broader picture. We're not able to get an accurate assessment. Please go on.
28% of deaths are caused by mostly preventable, communicable diseases and maternal, perinatal and nutritional diseases. Only 65.2% of the children aged between 1 to 2 years are fully immunized.
Everything is sourced to something or other, a fairly credible document. None of this is top of the head, either government documents or international agencies, WHO, sometimes even consultancy, globally recognized consultancy organizations, but everything is sourced. Therefore, there is some basis for these numbers. Where there is statistical inaccuracy in the country, we have to have some basis, some reasonable basis. Next, please. Next slide. NCD, which, including me, many healthcare experts for a long time have not really bothered much about. Increasingly now experts are talking about the burden of disease related to NCDs. Therefore, we thought this should be put there. This, I think we got it from KPMG, right? KPMG. And each of these things, what is the left one, what is the right one, Surya?
The left one is occurred in 2005 right is expected in 2030.
Okay. The blue is current or 10 years before. 2030, the year Dr. Beckham talked about. Everywhere you can see an expected increase in the disease burden, etc. Next, please. Again, these are very well known, these challenges, but will you please read them, Surya, just so that we can focus?
First one is low public health expenditure share, high out-of-pocket health expenditure, inefficient public-private partnerships, lack of accountability in public health care, unaffordable family care, doctors' accessibility in rural health care, decline in family care over-specialization, which leads to over-specialization, alternative systems integration.
Okay, next please. Just to show that this is Government of India budget allocation, it's a paltry 30,000 crore plus. I think the latest number is 38,000 crore. I don't know how much actually is being spent or whatever. So the detail simply glosses over the picture. It's very grim, that's all. I don't think we need to go into the table. Next please. This is total health expenditure. We have taken only some of the comparable economies. China perhaps not really comparable, but not the rich countries. This is the total health expenditure in society related to GDP. You can see from top, will you please, the colors are incomprehensible to us. From top, will you give, the big thick dotted line is India. Roughly 4%, numbers vary from 4% to 4.7%, exact number we don't know, public plus private together. But the rest of it from top, right top, will you please give us the names of the countries?
The first country on the right top is Vietnam, then China, Thailand, Philippines, India, Sri Lanka, and Indonesia.
This is the total health expenditure. Next one, please. This is public health expenditure. Thailand ranks the highest in Asia among these countries. 3.7% of the GDP is a public expenditure. Then China, then Vietnam. The other countries are roughly comparable. India still is somewhere at the bottom, but other countries are not much better either. Next one, please. This is health expenditure in purchasing power parity terms. Again, Thailand ranks the highest. China ranks next. The other countries are all roughly at the same level. Worst, of course, is India again. Select countries. The left bar in each country is the share of the budget. The right yellow bar is the share of the GDP, health expenditure, public health expenditure. South Africa, 14% of the budget, 4.33% of the GDP. Brazil, 6.93% of the budget. That seems a little wrong. I can't believe that the government budget in Brazil would be 2/3 of the GDP. There's something wrong with Brazil. I think we have to verify that number. I'm not sure about that. Russia, 8.42% of the budget and 3.15% of the... it's possible they were taken federal budget, but total health expenditure for the country. So there's some discrepancy in numbers. Bangladesh, 7.84% of the budget, 1.31% of the GDP. India, 4.55% of the budget, 1.28% of the GDP. Indonesia, 6.68% versus 1.2%. And China, 12.63, 3.11. Almost everywhere, India ranks the lowest, we can say again. Next, please. Union versus state. In most countries, if you notice the right graph, USA about 50%, Australia about 50%, when in federal countries about 40%, Brazil about 40%, India is somewhere about 20%. The total public health expenditure, the federal government's expenditure in India is again the lowest among federal democracies. The left graph is the actual expenditure of the federal government. While the numbers have increased, but as a share of GDP, actually it has come down from 0.37% to I think now 0.25% or whatever. So there is a declining trend in federal expenditure, and this is after the successive governments have promised that they'll enhance the expenditure, public expenditure on health. I think UPA talked about increasing from 1% to 2 to 3. They didn't give an exact number. This government probably talked about 2%, Dr. Srinath?
2.5% according to the draft national health policy,
Okay.
but that's not overall government policy as yet,
Yeah.
because it's still a draft policy.
So the actual truth is it's declining. The share of federal expenditure. Next one, please. Poor health record keeping. We've taken only births and deaths because this is the most preliminary record keeping, let alone the most sophisticated national health register and so on and so forth. The picture is pretty grim, with the exception of Sikkim, where the deaths are well recorded, not the births. I think 100% deaths are recorded in Sikkim. Otherwise, it's really appallingly bad. 50-60% recording of births and deaths. It shows that even the basic record keeping and understanding what's happening to our population, we have no clue, except some sample surveys, etc. Health records. Well, many interventions, we all focus on that. I think there's not enough debate on this issue of health records as an integral part of improving the health systems in the country. Next, please. This indicates these numbers are about the shortfalls of the PHCs and CHCs. Well, this is more about the normative thing, but frankly, in reality, even if they do exist on paper, in most cases, barring maybe Tamil Nadu, etc., they're really inconsequential. So this is more for general picture rather than for any detailed analysis at this point of time. Next, please. This is to give a general picture of hospitalization, public and private. It appears that about 35 per 1,000 population is hospitalized in India during a year. For how long, we don't have any data. We presume on an average must be 6 or 7 days. That seems to be the normal pattern after surgery in the country. Urban areas were 44 per 1,000 population. So 35 to 40 people per 1,000 population are hospitalized at one point or the other. That means they are actually inpatients. This is an important number in understanding our secondary and tertiary healthcare requirements. That's why we put up this graph. Next, please. Of them, 32% they depend on public hospitals in urban areas, 41.9% in rural areas. A majority, as we all know, depend on private hospitals. And the reasons why they don't use, again, reasonably well known: poor quality care, no nearby facility, waiting time is too long, and so on and so forth. Next, please. Again, everybody around this table knows these numbers. The numbers seem to vary from state to state, but overall the picture is clear. There's significant amount of high hospital cost borne out of pocket by the people. On the left side, those dark brown charts are the numbers state-wise, how much money they're spending per episode of hospitalization. The right side, for the same state or union territory, you have percentage of using public hospitals as private hospitals. The picture is very well understood by all of us, if I think well again. Next, please. Average expenditure. This is urban India. Earlier was rural India. Yeah. Next, please. Out of pocket. These numbers are from National Draft Health Policy. I'm not sure about the accuracy of the numbers because earlier studies, etc., they show different numbers, but because this is from the government document, we put there 68% of the expenditure in rural areas and 75% in urban areas is from household savings. The rest is borrowing, maybe selling assets or whatever, the rest. But earlier numbers were much more grim. So I don't really know how much is what. These numbers, for whatever it is worth, this is a number. Next, please. We all know about the impact of the out-of-pocket expenditure. Will you read what it says? Outpatient and government and private hospitals, right?
Yeah, the left side shows the incurred by outpatients. The right side graph shows the
2004-2014.
Yeah.
So the current picture of outpatient is 854 rupees for those who go to government hospitals, and 788 rupees for those who go to private hospitals or private doctors. And hospitalization,
It's 6,120 in public hospitals
Yes.
and 25,850 in private hospitals.
So, okay, again, this is pretty well known to everybody here, but just to complete the discussion. Next, please. Again, from the top, financial risk protection. Out-of-pocket spending as a share of the total health expenditure. India, again, is at the top among the countries we earlier have seen, the Asian countries, emerging economies, etc. Quickly, will you go down from top to bottom on the right end?
First one is India, Philippines.
Okay,
and,
the other three are
Vietnam.
clubs, so tell us the bottom two. China, I think.
First one is Vietnam, Sri Lanka, and then would be Indonesia. Then next is China, and the last one is Thailand.
So Thailand, again, has the best protection in the Asian economies, among the emerging economies. Because 3.7% public expenditure, you can see a correlation everywhere. India is the worst. China is next to Thailand generally. And the worst apart from India is Philippines, is it? Next to India.
Yes.
Philippines. Next, please. This is again very well known, but just to emphasize this point and make the government act with a little more alacrity. Officially, the policy exists, but in reality, you know what's happening. So we thought we'd actually put some of these pictures and take the actual numbers in terms of some of the drugs, generic drugs, or should be generic drugs. We've taken a few. There's no reflection on a particular company because at random we have picked up some samples from the drug stores and have taken the MRPs there and found out the actual cost of production of the API being active pharmaceutical ingredient, and we tried to see the markup. If you can see this nice, the nimesulide tablets, 525 rupees is the cost of production minus packing, whereas the cost of sale is, or the price is 62,500 rupees, 110 times markup. Cetirizine tablets, the markup is 90 times. 2,330 rupees is the cost of production. 2 lakh rupees is the sale price. Per kg this is, all these numbers. Then rabiprazole, next one please. This is, the markup is 140 times. 1,100 rupees is the cost of production. This market sale price is 1,52,000 rupees per kilogram. Diclofenac, 190 times. 550 rupees is the cost of production. 106,000 rupees is the sale price. Next one, calcium. This is particularly egregious. 21 rupees is the cost of production. Calcium, we all know, is a pretty simple salt. 600 times is the markup. 127,000, sorry, 12,700 rupees. 600 times is the markup. And then pantoprazole, 45 times is the markup. 4,300 rupees versus 189,000 rupees. Next slide, please. The government allocation apparently is 0.1% of GDP. That means out of the total public health expenditure of assumed 1.2, 1.3, we are spending only about 7 or 8% on drugs. Whereas surprisingly, at least to me it was when I first discovered it some 10 years ago, a lot of patients actually they find the hardship in purchasing medications. In a large measure because of this high markup, etc. Out of the total medical expenditure, around 72% in rural areas and 68% in urban areas. That is the cost of buying medicines. Very significant part of the out-of-pocket expenditure is surprisingly cost of buying medicines for the poor. This was actually quite a bit of a surprise to me. I didn't realize that. Indian market is now about 100,000 crores. Domestic market, pharmaceutical market, 100,000 crores. Our sense is, various numbers are given in various reports, our sense is easily 50 to 75% savings are possible in terms of the cost incurred by the system, whether it's the patient or the public health system or whoever bears it. We can bring down costs significantly if generic drugs are made available wherever there is no existing patent. Where the patent is there, there's nothing we can do. But over-the-counter drugs and other drugs where the patent does not exist, we can significantly bring down the costs. And generally speaking, 80% seem to be the generic drugs. Only 15-20% would be the patented drugs where you have to go to the particular company. Next, please. Go on. We'll quickly run through them. The beverage model is Great Britain, Spain, Scandinavia, New Zealand, Hong Kong. We all have fairly good understanding. Single payer, government-based, the total cost, and so on and so forth. The Bismarck model, Germany, France, Belgium, Netherlands, Japan, Switzerland, Latin America. General insurance-based model where a significant part of the burden is borne by the state, but also the companies pick up, and more complex model. The national health insurance is a single insurance, single payer model with insurance, unlike the British and beverage model, is Canada, etc. Out-of-pocket, India, Africa, South America, etc. Then free market, United States. Next, please. So these are going into some more details of some of the select countries. UK, we all understand. Next, please. Mexico is also making some significant efforts, apparently. 50% publicly funded, 50% private sector, but with some systems in place. Next, please. But you can see in the top, 3.2% of the public expenditure. Go back to UK. 7.6% is the public expenditure on health. I think that is mostly the expenditure, right? Probably the private expenditure, Shiva, would be no more than 0.5 or
84% of all healthcare expenditure in UK is government.
So the balance 1% would be, another 1% would be private sector, that's all. IMR, MMR, you can see the thing, 4 IMR, 9 MMR, 9 per 100,000 births, right? Life expectancy 81 years. Next, please. Even Mexico, IMR is 11. Number is wrong?
No,
we could verify.
IMR 4 is very
It's too low, too low. We'll verify. Let's verify if the IMR is right. Normally single digits there, but probably not 4. Yeah.
It's very low.
Mexico is IMR is 11 and 38 is MMR. Life expectancy is 77. Next, please. 3.2%. Sri Lanka is actually a very interesting case. 1.4% public expenditure. And yet they have significant outcomes relative to a country like India. 8 and 30, again, let's verify whether IMR is 8 in Sri Lanka, but that's the number we have. Life expectancy 74. Next, please. Thailand 3.7, we have seen Thailand quite a few times earlier. 11 and 20, 74 years. Next, please. This is Norman Bethune. Just for us, I don't think government is, go back. Government will be impressed with this kind of logic. The best form of providing health protection would be to change the economic system which produces ill health and to liquidate ignorance, poverty, and unemployment. The practice of each individual purchasing his own medical care does not work. It's unjust, inefficient, wasteful, and completely outmoded. In our highly geared modern industrial society, there's no such thing as private health. All health is public. The illness and maladjustments of one unit of mass affects all other members. The protection of people's health should be recognized by the government as its primary obligation and duty to its. But it's a moral argument. So I'm actually breaking my own pledge. This doesn't appeal to the government. This is more for us. Go on. A committee, National Commission, of which Sujata Rao was the secretary, and she wrote the report basically, but the chairs were, I think, the then finance minister and the health minister, Chidambaram and Ramdas, respectively. They gave a very detailed report, and subsequently, go on. Next. Subsequently, Dr. Srinath, it's our good fortune that both are here to guide us. They went into greater detail to come up with a roadmap and a model to go towards national universal health care. Next, please. This is what really we have to strengthen. We tried to make a case and to take it to the government, but we require much more here. Dr. Mohan Guruswamy is supposed to join us today. I'm sure he will. We require a lot of economists to do serious work and see that the numbers are totally acceptable, etc. We all know that about 86% of the private health expenditure is out of pocket in the country. It ranges depending on the source between 85 and 90, etc. Its public system is underutilized. For instance, in the bed strength, etc., we always talk about PHCs and CHCs. PHC beds are more or less unutilized. CHCs, I don't know the number exactly, but my sense is no more than 25-30%, if at all, are utilized. The rest, they exist. There are many number of CHCs. Nice buildings exist and nothing is there. No staff, no patients, no nothing. Unregulated private market, we all know what's happening. High cost, low impact. Curative treatment, obviously, is overcapitalized. If our costs go up in healthcare, the benefits to society do not flow commensurately. And the consequence of high out-of-pocket expenditure, Dr. Guruswamy, we were just now talking about you at this very moment. Please come. Come. Please be seated here. Just a second ago, I was taking your name. And the context was that we have to make a compelling economic case to the government or political parties about the need for something like universal health care. A mere moral argument will not suffice. While it will suffice those of us around this table, it looks like there's going to be some resistance in this idea of single-payer system and government-owned healthcare system. So these slides are really about the outlines of a case to be made. The numbers here are, because of out-of-pocket expenditure, are about 85 to 90%. Any number of reports say 25% of the total number of patients admitted to hospital, they fall into the trap of poverty again, descent into poverty. I tried to do some reconciliation. Just go back, please. No, go back. The earlier one. Yeah. If you notice, the earlier slide, one of the earlier slides talked about 35 to 40 persons hospitalized out of 1,000 population per year. That gives us a number for the whole country of about 5 crore people, roughly 50 million people, 40 or 50 million people hospitalized every year. And of them, if we're assuming that 25% are falling into poverty, that comes to about 12 million. So where has this 50, 60 million people come? 12 million households are falling into poverty. If an individual is hospitalized, it's the household that is falling into the poverty trap. And therefore, multiplying this 12 million by 4 or 4.5, it comes to that 50, 55, 60 million. Because we have to reconcile the numbers because the data is somewhat sketchy. Okay, good. Okay. Next, please. Again, the second economic argument is this whole labor productivity issue. This is, I think, borrowed from
the KPMG report.
KPMG report. But I'm not able to understand, maybe Dr. Guruswamy can explain to us, the left and the right ones. These are essentially about productivity of various countries, Singapore being the top and India being the bottom. The left slide talks about ranging from 15 to 113 to 133, India being the lowest, dollars. I don't know what these dollars are, per hour productivity or whatever. Right one seems to be annual productivity. Again, India is the bottom, Singapore is the top. Something like $120,000 to India's case is about $10,000 or under, or thereabout, annual productivity. But the left graph I'm not able to figure out. We have to understand what it really means. Next one, please. There's another economic argument is there is a number given in which study, Surya?
It's study on global burden of disease. 2013.
So GBD gives a number. They converted this disability adjusted life years to actual loss of years in a particular year. 37 million years is what is reported. Now, how accurate that is, how to calculate, I cannot really answer that. But if you take that as a number, then we try to do some ballpark back-of-the-envelope calculation. This is very crude. This will not stand the rigor of economic scrutiny. But for what it's worth as a starting point, if you take India's GDP per capita and multiply this by the million years lost, then we're getting about 3.7 lakh crores or 3.83 lakh crores or 3.83 trillion rupees. That is roughly about 2.8% GDP. You must avoid red on the slides. Red is a terrible color on slides. Put a low or something. 2.8% of the GDP. Next one, please. Then we tried to compute the economic loss on account of out-of-pocket expenditure. The earlier was a productivity loss or income loss. The other is out-of-pocket expenditure. This again comes to, straight away you take the private expenditure, total expenditure minus public expenditure. Then in that you assume 90% is out of pocket or 85% out of pocket. You are getting these numbers. This is coming to 1.89 lakh crores. And if we take the two of them together, sorry, this is coming to 4.48 lakh crores, is it? Yeah, 4.48 lakh crores. Next one, please. If you take both the numbers together, loss on account of daily and loss on account of out-of-pocket expenditure, you're coming up with 4.14 lakh crores per annum. This is only for the poor. We're assuming, again, making a big assumption that 50% of this burden is on the poor. Poor and middle classes, not the rich. Exclude the top 25, but this is a big assumption. We don't know because at least we haven't seen any specific numbers on this. We tried to get an aggregate number. We took 50% of the total loss suffered and said this is the poor people's thing. That is about 4.1 lakh crores. And that comes to about, at the current rate, about 3% of the GDP. Only borne by the poor. That is the number we're trying to put here. If you take the total, it's about 6% of the GDP. Next, please. This is NCDs. The earlier, if you remember the slide, I think KPMG came out with that report. They actually put a number. From 2012 to 2030, they come up with a number, something like $3 trillion is going to be the burden on the system, on either loss or cost, on account of non-communicable diseases over 18-year period. You obviously can't do an average per year, but that still comes to about, I think, $160 billion per year. But obviously today it will be maybe $60–70 billion. It will be close to maybe $250 billion by 2030. But this is a number I thought we should put here. Again, another argument. Next one, please. Those people who are falling below poverty, the same numbers again, just to compare. French population is 66 million, British 64 million. India, we're talking about 63 million people falling below poverty on account of ill health alone. Roughly equivalent to population of Britain or France every year, falling below poverty because of ill health. Next, please. This is about possibility of employment. Again, we only have some vague numbers. Dr. Srinath also pointed out in his report, and global studies show that world over in developed countries, typically 23 per 1,000 population, up to USA 38 per 1,000 population are employed in healthcare. India is 0.28 per person, that means 2.8 per 1,000 population. Is it right? .28% or 2.8 per 1,000 population. Is it right?
It's 0.28% of health workforce in total population.
That's right.
Yeah.
So per 1,000 population will be 2.8, whereas 23 is what you cited, Dr. Srinath. Roughly 10 times. We are not expecting that ever. Even if you assume half of that, if you put everything in place, still we are looking at 10 to 15 million employment only in healthcare sector. There's a huge potential for gainful employment in healthcare sector, apart from improving the quality of life. Again, another economic argument we thought we'd place before the government in the current climate of job creation and so on and so forth. Next, please. Then we know the problems of public sector provider, what happens, fee for service, then capitation payment model, and then traditional insurance model. Earlier we also briefly discussed that. Please.
On this one, I'd like to discuss on the traditional insurance model. There are a few issues which is not correct. At first selection of beneficiary is actually not is wrong, because if you have compulsory, mandatory enrollment insurance, then there is no at first selection. Everybody will be enrolled. If you look at the causes of avoidable suffering and escalates cost, if you have a good purchasing function and you use ARGs, etc., then this is one of the issues what you normally advise to countries in order to get a hold of the escalating cost. So on this one, I think that number 4, I would not agree what was mentioned on the slide.
Excuse me, that was put to mention United States model of private insurance.
Yeah, this is not publicly funded insurance model. This is.
But that's not traditional. The US there's nothing traditional about the US. There's any country is not traditional than the US.
Okay, we stand corrected. Basically, an insurance-based model.
But insurance model, this is not correct.
Competitive insurance, private insurance model. Let's put it that way.
Sorry, I'm from the Netherlands. I'm the only country where we have a private insurance and all private providers, and it does not apply. If my colleagues are physicians and they're complaining bitterly about insurance because really the purchasing function of the private health insurance is so strong that they get really the best deal, etc., and they're making life very hard. So I really think from that your information and then the principle of insurance is not understood on this slide. And it's important because I think what I also see from, let's continue first.
We will, with your office's assistance, we will redo this. Okay, it's a good point. Next one, please. This slide we put up, this is out of 50, India's rank is 51st, but out of 54 countries that were included, we've taken the countries with more than $300 billion aggregate GDP. There were actually 55. Hong Kong is excluded because we don't have data. Obviously, Hong Kong is way above many of our countries, but we don't have specific data. Therefore, 54 countries. India ranks 51st in disability-adjusted life years, if you take one measure in terms of healthcare outcome. Singapore ranks number 1, Japan number 2, Italy number 3, Spain number 4, Australia number 5. United States, which spends the highest per capita amount on healthcare, is number 24. The reasons are twofold, the reason why we put this slide. One is to indicate that higher expenditure does not necessarily equal to better healthcare. It is the way the system, obviously we require more expenditure in Indian context, but it's not merely more money and more health. It's well known among experts, but it's not adequately understood by many people. The second is that the only countries worse than India in this list of 54 countries are countries that are beset by either anarchy or terrorism or civil war. The 3 countries are Pakistan, South Africa, Nigeria. South Africa actually spends more money than us, but obviously because anarchic conditions prevail, because violence of a very high magnitude, etc. That must be the reason. But otherwise, there is no significant country in terms of GDP which is so terribly bad as India. That's something that our leaders and our government functionaries, I think, must be enabled to understand adequately. You want to make a comment here? No. Next, please. That's the point we're making. Spending does not necessarily improve the outcomes automatically, unless we also build a system which actually delivers greater efficiency. Next, please. The PHC and the primary system generally has failed in this country. While on paper we have it, we all understand that. And the drug supply, as these slides demonstrate earlier, and as is well known in the country, despite our policies in Hathi Committee, we haven't done enough. Only recently there's some beginning, but not enough. I think these are the 2 critical things in primary care. Next one, please. Secondary care is again pretty ineffective. While the number of secondary care hospitals, we are talking of secondary care in a loose sense, the community health center. The actual hospital with 3-4 specialists and some 30-40 beds, sometimes 50-100 beds, area hospital, etc. In most cases, they are not functioning for a variety of reasons. These two seem to be our weakest links, where tertiary care is there overcrowding, inadequate infrastructure, but actual care, within the available circumstances, there is some effort to make, to provide. Therefore, we feel that we must look at primary care. Can we bring in the private sector completely, but with public funding and with choice, and integrate the existing institutions with the private general practitioners? Secondary care, can we bring in competition between small nursing homes, private nursing homes, and the 30 or 50 bedded government community health centers? Next, please. Tertiary care, they're overcrowded because of poor primary health, and therefore even primary care patients actually go into tertiary care hospitals. Outpatient departments must see in government hospitals how terrible it is, underfunded, overcrowded, poor infrastructure, and therefore they simply are not able to deliver to their capabilities, and they are doing things that they should not be doing in any case. And therefore tertiary care, the problem is not so much competition or other things, but the problem is actually increasing efficiency and making sure that referrals are there, and more funding and better infrastructure, and of course accountability. Next, please. I think everybody around this table knows about the MCI and many regulatory agencies and their spectacular failure. And Sujata and others, they have actually done some study and gave a report to the government. Government, I think, is now looking at it. There's a committee now. But in general, regulation and accountability are our weakest links. Next, please. From these broad conclusions, what we're arguing is primary care, in the absence of choice and accountability, the public system, while it's necessary, it will not function. And therefore, we have to have public-private partnership in some form or the other. Secondary care, because of overtreatment in private sector, we have to have choice and competition between government providers and the private providers on equal footing. Tertiary care, private sector will not help. Overtreatment will result in a highly overcapitalized healthcare system. Therefore, create centers of excellence and fund them better and have better monitoring and give them satisfaction, rather than look at private sector coming in. Because right now the model appears to be in most of India, tertiary care, go to private sector in the name of Arogyasri or some other model or some insurance model. But ultimately underfunded government hospitals continue to be underfunded, and overall outcomes seem to be increasingly as bad as they were before, despite higher expenditure. Therefore, tertiary care model currently adopted in the country does not seem to be working, and that's the danger that India is actually in. We're pretty much following the American model, unconsciously or subconsciously. Next, please. And this is the last slide here. Obviously, if 70% of people are taken care of, on paper our needs are met, because we assume 30% people, they know how to get that, they have enough income and they go to private sector or they get their private insurance, etc. But the problem is, unless at least a significant section of middle class is also included in this government funded scheme, there is no voice and there is no accountability, and the services will ultimately decline. Therefore, our argument is, perhaps it should be with the government, that while we expect only 70% of the population to actually utilize the publicly funded services, we must not make it selective. Everybody must have access to it. It's their choice. We are assuming that a significant section of the middle class also will utilize this, and therefore that will put the pressure on the system to improve the accountability and delivery. Otherwise, a targeted public health system probably is more likely to fail than a system which actually takes the middle classes on board. I don't know whether it's the right argument or not, but I think we have to take a call on that. Next, please. Move on. Next. Next. That's it. Now, Shiva, your call.
Thank you very much for everybody. Surya, do you want to put the next one? Yeah, I'll show thumbs up for the next slide. Yeah. I'm thankful to Dr. JP for giving this opportunity. I feel really privileged to interact with all seniors and experts who are all leaders in their chosen fields and also very committed to improve the healthcare in India. So,
Shiva, just go into the model.
I will just go into model
We'll save time.
quickly. Yeah. Okay. So we made a remarkable progress, but we know that the disease burden has been going up still, despite our GDP growth in the last 25 years. The question is this avoidable? Some people argue the reasons behind our healthcare failure is outside the healthcare domain: poverty, loss, no infrastructure, no institutions, etc., etc. Okay. Do you want to come back once, Surya? Just give a glimpse of actually. Yeah. Okay. Stay there, yeah? Okay. So we've seen the growth in the last 25 years following the economic reforms. It has been immense, but we don't have a proportionate change in the healthcare indicators. Next. If you see the DPT vaccination rate, it has stayed same in the last 25 years, despite our GDP growing 7 times in the last 25 years. Yeah, next one. One question is actually there seems to be a lot of discussion between the economists and the intelligentsia. The very mention of universal health care triggers lots of emotions, saying that it's a bloody socialist or communist. And there seems to be widely apart in terms of the philosophical stand. But actually there is no much difference. We all support liberal economics. The only thing is healthcare is a little bit different. It's not a usual commodity. And that's why we want the government to intervene. And this is not a moral argument here. There is an economic argument for this. So there is no much difference in the stands of two groups who are proponents of universal healthcare or opponents of universal healthcare. We are all for liberal economics. That we need to make clear to the economists who are with the government at the moment. And there is another strong moral argument or economic argument, I would say, as well, because all the citizens, they all want good health and they want the government to act. So how can the government act? That's the question. But government needs to act. That is no question. So what government needs to choose is a pragmatic approach to get the best value for the citizens' money, leaving all the ideologies aside. So it doesn't matter a socialist or a free market champion, but you need to get the best value for the citizens' money, and that's what we want. So it's a pragmatic approach. Other thing is, I just want to spend a half minute here. The reason is you can't understand other models unless you understand the basic philosophy of healthcare in the free markets. Is healthcare a commodity? It's a, in the economic sense, if you argue that it is a commodity, then it is completely a different kind of commodity. It's not like buying or selling soaps or cars. The reason being, this is the most important point we need to understand, which is information asymmetry. The consumer doesn't have any information. The seller has got all the information because the information is too complex. And the second thing is, the demand is not based on a desire, but based on the need. And who decides the need? The provider decides the need. The consumer doesn't know whether it is needed or not. For example, give me 10 minutes, I can convince each of everyone sitting in this room that you need a knee replacement in the next couple of weeks. In a normal knee, yeah? So that's the very important point here. We need to understand when we put health in the economic sense. And the second thing is uncertainty of the need. So health is a lottery. There's a lot of risk of the illness. Burden of the illness is huge, and unless there is a mechanism for pooling of the risk, individuals cannot cope. And the third important point we need to understand is the concept of externalities, which is if one person is treated, the society benefits, not just that person. So it's got an effect outside that person, which is the whole society benefits. For example, if I have a communicable disease, say I have a TB, if I get treated, you all will be benefited because you won't contract from me. And that effect would be immense if if you are covering the whole population rather than leaving it to the affordability of the people. And that's where economically a public funded healthcare is effective than a private healthcare. Okay, so what is the best value for money? So if you look at the, go back, yeah. If you look at the public and preventive health, obviously there are no markets. So free markets do not work here. If you want to control the vectors, the mosquitoes, individuals can't take the action. It has to be collective action. It has to be public funded. There's no question about this. In addition to that, a public and preventive healthcare is a very cost-effective domain. The penny spent here, we will be saving pounds. Sorry, talking in a British language. Yeah. Pounds in terms of tertiary. Yeah. Okay, next one. So look at the primary care. So here, actually, the primary care has got a lot of positive externalities as well, in addition to public care. As I talked already, the communicable diseases, if you treat one person, other person will be benefited as well. In addition, if you treat the non-communicable diseases as well, it creates a sense of culture towards a healthy lifestyle, which affects the other persons as well, indirectly. And this won't happen if you leave it to the affordability of the people. And so that's why public funding is, or universal funding is quite cost effective in this sense. On the other hand, in a private funding for primary care, there is no incentive to prevent disease. I will rather let it get worse so that I can get more money out of your complications. So that's the main important bit we need to understand here. Yeah. Coming to secondary care, we have all seen actually government has failed completely in providing secondary care, so they're inefficient, corrupt. On the other hand, in the private setup, there's a lot of over-treatment and this is expensive, it's clear. So it's not very clear which one can be cost-effective. It all depends on the model you employ in terms of secondary care. However, tertiary care is completely different. Tertiary care, we have fantastic examples of centers of excellence like AIMS, PJ, NIMS, and also institutes under the NGOs like Tata or Aravind or Sankar Nethralaya, LV Prasad, which all showed actually. So a very cost-effective tertiary care can be provided on a non-profit basis. How does this work? Being an alumni of PJ, I know this very well. The culture itself is completely different in these centers of excellence compared to other government hospitals. There is a culture of professionalism, there is a culture of accountability, and there is a culture of pride. In addition, first of all, these centers are providing huge amount of clinical services for a minimal cost. On the top of that, they're providing a vast amount of training. They're training future doctors, future leaders, future nurses. On the top of that, they're providing excellent research facilities, which goes into the community. This is not a tangible effect. We never measure this, but if you there's no way to measure this as well. But if you measure this, the effect is immense on the healthcare of the country. So we got the best models where we need to nurture on. Yeah? And we know where our deficiency, Achilles heel is, which is a primary care, where these kind of culture does not exist because of obvious reasons. So the clear case is here, the economic case here is the public funded healthcare is cost effective in tertiary care and preventive and public care. Public funding is cost effective in primary care, but we'll look into whether provision need to be public or private. Secondary care is a little bit dodgy, so look into that again. Now we've seen
this is all covered. Just okay. model. We are losing time.
So next one, please. Yeah. Next one. Yeah. So stay there. Yeah. So how do we spend money smartly? I think we need to focus on these three important domains, which is cost-effective interventions, high-quality institutions, and appropriate models. Next one. Cost-effective intervention. This is not rocket science. We all know which are cost-effective. So again, as I said, in all these areas, a penny spent will save pounds. High-quality institutions, and this is the very important area. So as we have seen, I feel that we need a multiple institutions institutions where devolution of power such that we can reduce the chance of corruption helps us. The next thing is in the 21st century, in 2016, we have the greatest advantage of technology. So if we don't use the technology for monitoring, for improving the standards, we are missing here. Okay, so the technology must be utilized properly. Okay. Now, we sort of concluded that, okay, so we're going for public-handed healthcare. So now, what kind of model should we implement? What kind of models are available? Here, I wanted you to spend a little bit of time again, because the terminology is quite confusing. If you look at the healthcare literature, there are a lot of terms used, actually. Some are equivalent, some are not. First model is simple, which is the government-run institutions, which is public providers. Okay, so next one is the public can fund, but private individuals can provide, private institutions can provide. This is a private provider. So some people use the term PPP, which is a public-private partnership. This PPP can be, it can be done in two methods. One is fee-per-service model, where you pay the private provider for the services that are provided. For example, for the operations, for the hospital admissions, you charge a certain amount of money, and you reimburse the private providers this certain amount of money. This is a model of RSBY or the Aragyasri. Here again, two different systems exist. If you want to use the term insurance, you can say this as an insurance-based scheme with a government acting as an insurer. That's one way of saying it. Or sometimes actually a government can fund a private insurer, which happened actually in the initial stages of Aragyasri, then it has moved to government itself acting as an insurer. So these terms are the insurance-based schemes funded by government is equivalent to a PPP fee-per-service model. The next model is private providers, which is a PPP, being paid on a capitation payment. So capitation payment is you pay the private hospital or private doctor annually based on the population they serve for the services they provide. Here, indirectly, the provider himself or provider itself is the insurer. So they take the risk, basically. Okay, so there are good things and bad things in these two models. In the first kind of PPP model, which is a fee-per-service model, clearly there is a very high power incentive to provide the service. That means you do an operation, you get money, as simple as that. So whether it is indicated or not, that's a different story. So there is a high chance of corruption unless it is highly monitored. We've seen the horror stories of Aragyasri. Well, of course, it has immensely benefited many people, but on the other hand, we've seen a lot of horror stories where the villages where the wombs have been taken off without indications, discs have been removed, or maybe cut was put on the back without an operation for thousands of people. Yeah, so there's a lot of problems with this model unless it is monitored properly, and the monitoring is not easy. Whereas on the other hand, if you go on the capitation payment, yeah.
Don't go too long.
Okay.
There's a lot of expertise in the
Okay, yeah, thank you. Capitation payment model, there's a problem with the undertreatment. Okay, next one, please. Yeah. Okay, so this one again, the whole model is based on this. So we think that, next one, public health is a case for a fee-per-service model. Primary care, so we think that there's, the capitation payment model can be cost-effective. Fee-for-service does not work because of the high-frequency events in primary care and high transaction costs. In terms of secondary it's a bit difficult, it's a bit complex, so there are different approaches to provide secondary care. One is a tertiary care, centers absorbing some secondary care in the big towns. Other is carefully using fee-per-service model for some emergency services in remote areas. Other thing is that there is a scope of capitation payment model, but not now in the future, probably. Okay, next one, please. For the tertiary care, we know the centers of excellence can provide the best cost-effective service. The next two domains are drug delivery and diagnostic centers. Here, if you give it to private sector in a fee-per-service model, there's a high chance of over-treatment They can prescribe drugs because they get money. Whereas if you go for a capitation payment model, there's a chance of undertreatment. They won't do it because they get money anyways annually for the patient. So probably balanced approach is a government-funded drug delivery centers and government-provided drug delivery centers and diagnostic centers. Yep. Well, this is a basic structure. It's a bit of a complex diagram, but perhaps we can spend a half minute here. We propose a system of a district health board being a unit which will spend all the money for primary, secondary, and tertiary care. Haven't included public health, so must have included probably. Which is funded both by the central and the state government, half and half proposing. And similarly, there's something called a Central Health Monitoring Agency, which is a technology-based, so which gets the data from all the primary, secondary, and tertiary care centers and uses the data not only for the payments, but also for monitoring and maintenance of standards. And thirdly, a drug supply agency which procures drugs, as discussed before, generic drugs, and maintains drug delivery centers across, which are run by the government and dispense the drugs based on the prescriptions. And of course, there are several institutions for quality and accountability. Now, this is a primary care model, the basic model we propose. Essentially, we contract primary care physicians annually or biannually, or it can be debated, and give them money basis of the population they serve. Okay, and the population they can register need not be geographically restricted, such that there can be a competition among a group of family physicians to get more patients based on the services they provide, so they can increase the standards and attract more patients. And all the registrations are based on our unique ID system, which is Aadhaar card with a biometric login. Of course, this costs money, but I think in the long run, this is going to be very useful. And these biometric logging registrations and further the health records should be logged in as well based on the Aadhaar card with an extensive computer network, which will be linked to the agency CHMA, so who will get the real-time data about the patients, their registrations and everything. And this data will be shared with the particular district health board so that they can see how many patients are registered with a certain particular doctor, and they can do the payments based on that. So, yeah, sure. Well, yeah, well,
I'll address that.
That's true. We need to integrate that.
Ritaji,
Exactly, yeah, that's true. We need to integrate the existing PHCs
nothing
as well.
existing at the primary level will be changed, will be removed. But we have to integrate, because we know how difficult that is. That's not worthwhile also. Completely link them, integrate them. Therefore, can you go into our primary health thing, those slides? There, Shiva, like all experts, you're making it a little more complicated and less lucid. We will try and make it simpler. Primary health model, quickly. We'll just go through those slides, we'll understand. Slide 57, I think. 57, fast. Basically, what we're arguing is, let us imagine a population of some 100,000. Let us imagine, typically there's also a small town there, not a big city, not a municipality also very often, but maybe a 25, 30,000 big village, small town kind of thing. Let's imagine that's where the practitioner actually be there. No matter what we say, ultimately it's unlikely that a doctor will go and live in the village physically in the 600,000 villages of India. We're envisaging about 200,000 doctors of India in private sector. If they are willing to come forward, if their remuneration is adequate, and that will come to it, they will all be part of this program. For a 100,000 population, let's say a pool of 15 or 20 doctors is available. They will be certified. They may be special certification for about 3-4 months and family health alone, no matter what their qualifications are. Some special sensitization and certification, family health.
But, MBBS degree?
MBBS, mandatory MBBS. This all. This is all allopathy driven, MBBS driven thing. Yeah.
Whatever the qualification, huge number of RMP self-started.
No, because like it or not, we have to be in 21st century now. And there are enough people. Now, here is the essential element. The people voluntarily register with any doctor of their choice. It's entirely up to them. That means the word of mouth, their own experience, reputation, credibility, and every year or every 2 years we can decide the details. They can change the registration. Therefore, there is now an incentive of the private sector to function. And typically we expect about 5,000 on an average per this family practitioner. India cannot afford 2,000 population, etc., nor is it required at this point of time, because the basic public health needs at the primary level are taken care of by the PHC. This is essentially outpatient and patient registers and coordinating the primary healthcare functioning, etc., etc. And per capita, depending on the number of people registered, we expect the family to be a unit, but again, that's an issue to be resolved. Whether individual should be a unit or a family, but we believe ideally family may be the unit. But I'm talking of 5,000 population being registered with the physician. And there will be a per capita payment, let us say 600 rupees per capita. That includes all services that the physician has to go, including lab there, the health information there locally. He may require 1 or 2 nurses and things like that. This is in addition to the PHC expenditure. And we expect only about 70% of the people of India to be registered eventually. Initially, maybe we start off with 50%. But 30% of Indians will probably never utilize this. Because, but let's see how it goes. And if they don't utilize it, the burden on the system actually is reduced. Will you go to the next slide, please? Next slide. Next, you put too much of, next. Okay, the PHC exists. It does those functions. Will you read those functions of the PHC?
Free generic drug supply, diagnostics such as X-ray, etc., field visits and epidemiological surveys, local nutrition and sanitation programs, mosquito control and disease control programs, etc.
No, the right one.
The family physician, he gets patients registered. He maintains electronic records, basic diagnostics like urine and blood test, referrals. He refers it to the secondary care, primary and preventive health care.
Essentially outpatient care.
Yeah. Free generic drug supply.
So they have to be fully integrated, but for these services, the doctor will get X amount, maybe 600 to 700 rupees per capita, including the cost of his own outfit, his own staff and so on and so forth. 5,000 patients, that comes to about, if you're talking about 700 rupees per capita, about 30-35 lakhs per annum, which is not a small sum.
700 would be paid for by the government.
By the state. By the state. So really strengthening the primary health sector. And the flip side is that there shall not be a patient going to a hospital in government sector at any level, tertiary or secondary, without a reference. But without this, the reference will not work. Without reference, the system will not work. So they have to go together. That is the essential feature. And these doctors must be specially trained and sensitized, and they must be linked up with the health information system, CHMA, that Shiva is mentioning. And the costs are coming down to a decent number, but it's an affordable number ultimately when we see the big picture. Next one, please, quickly. Let's assume 700 rupees per capita. We may start off with 500 or 600 today, but let's assume down the line by 2022, 700 rupees per capita. We are expecting only about 70% people to be registered. We don't know. In the whole country, it is urban, rural, rich, poor, etc. Pardon?
Very significant percentage.
Yeah, 70%.
Almost everyone who really should.
Yeah, that is eventually. Today we'll start off with 40-50% if we roll down. But within 5-6 years, we expect if the really service is good, they must register. Therefore, 70 crore people or 100 crore people, that comes to 70,000 crores. This is going to be the biggest cost if we're really serious about healthcare in the country. Other things are really add-ons and improvements, but this is going to be the biggest annual cost. The cost of, we put the current costs also. The PHC is assuming, we don't know the exact number, PHCs and other structures today are costing 25,000 crores. There are 25,000 PHCs, average cost, Sujata probably knows better. My sense is, Sujata, maybe 50-60 lakhs per PHC is the expenditure now. So we put actually a more number, 1 crore per PHC or something like that. So that continues altogether. Plus the new institutions that you require, health informatics and other things, etc. We don't know anything. So we put another 25,000 crores. So all this is coming to 1.2 lakh crores. The strengthening of the primary system on a per annum basis, this is the kind of expenditure. Of that, already current expenditure is some 30,000 crores. The new expenditure is about 90,000 crores. This is the biggest additional cost by 2022. The rest of the other things are actually marginal cost. Some costs are there, but they're not of this magnitude. The broader sense is that without private doctors coming in with an incentive to perform, and with choice incentive comes in, and without adequate money, there's no incentive for them. And therefore, there is inbuilt accountability.
The doctors are more likely to come, as Sujata will tell you. The government of India, we did offer financial, monetary incentive. We also suggested that if those doctors who are ready to serve in rural areas, we would sort of give them preference for postgraduate admissions and so on. Actually, it didn't work in most states. I think a private practitioner may well be more successful. I don't think we ever really approached
and this is a very sumptuous money, 2.5 lakh rupees or 3 lakh rupees per month. And if there is a cost of, let's say, 1 lakh rupees for the other staff, 2 lakhs is still his income or her income. It's not a small amount.
At the end of it, you also expect him to give inputs for preparing a national health register.
Exactly.
So that, of course, is a great technological challenge itself, and they have to be faced with that.
Can I really encourage now the presentation to really go? It is finished because I think it's one thing you should know from, please, I think we're all quite experts over here, and listening to a 45 minutes presentation is killing. Anything more?
Yes. Move on to secondary. We'll just, in 2 minutes, we'll complete everything. Go on. Next. Next. Secondary care, we have 5,400 community health centers apparently in the country. While the number is not really uniform in terms of per unit population, UP has a very large number, surprisingly. But what we thought is, we'll take a unit of 200,000 population, let us say, because that is roughly the number served by a CHC on average today. There'll be one CHC, plus there'll be small nursing homes, 30-bedded nursing homes, 30, 40-bedded nursing homes, where typically the wife and husband, they both practice, they have beds there, they also live in the same premises, and they are providing decent care at a moderate cost, and there is trust. If they can be brought in on fee-per-service model, but competition, both the community health centers and they must compete. That means CHC eventually will not get any salaries. Initially, they'll be phasing out the salaries and move towards billing and payment to them also in time. Basically, there is competition model between public and private providers, but only for secondary care, select interventions, and with the costs and the quality of care, the protocols being clearly established and monitored. That is the broad model. Let's go to the numbers.
Who's monitoring?
We'll come to that. An RHT, in fact, that's the key thing that we have to. There are about, right now, in the 5,000 or so, 5,400 CHCs, about 1,60,000 beds. We're assuming that we'll require another 300,000, 400,000 beds from private sector. So there will be competition between this 1,60,000 and 350,000 private sector. 500,000 beds should be adequate if you take the numbers of 35 patients per 1,000 population. And you also take into account tertiary care, including district hospitals and teaching hospitals. This seems to be reasonable. Per bed, let's assume 10 lakh rupees per bed per year, which comes to roughly 3,000 rupees per day, which is a decent sum at that level. It's not a small sum. That's coming to 50,000 crores. And let's assume there's some other institutional support required. The regional health trust, Dr. Bekadam asked, who is going to monitor and how to constitute that and all we have to decide, but there's going to be a mechanism there for all that, and ombudsman system, etc. Let's assume another 15,000 crores. We are looking at 65,000 crores expenditure in secondary care, of which roughly now, I presume about 7,000 or 8,000 crores, 10,000 crores is being spent. For CHC, expenditure should be 1.5 crores right now, if they're functional at all. So this is for the secondary care. Tertiary care. Move on. Move on. Tertiary care, there are 550 district hospitals in existence. Typically, they have 300 beds. There are 200 medical college hospitals in existence, typically 1,000 beds. Actually, they have more beds because of the pressure. Too many people are coming in. Therefore, many hospitals have 1,500 to 2,000 beds. But 1,000 beds is what they're expected. And if it's not overcrowded, then they will have only 1,000 beds. But the cost typically now is they're spending about 150 crores per year, the teaching hospitals, about 30 crores per year, the district hospitals. They're actually functioning. Unlike other institutions, these are functioning but overcrowded. Delivery is inadequate, sanitation is not good, funding is very, very inadequate, etc., etc. But if there we bring in private sector for improving the infrastructure and give them money for maintenance as well as the capital cost, plus we actually increase the budget for these hospitals, very much like Nizam's hospital or the institutions of excellence function, bring in those practices. But here, there is no pay for service. This is actually like a hospital is run by the government. We have to figure out how to make it actually effective, because they're actually functioning right now. Because competition at this level is not desirable is the general feeling. The moment corporate tertiary sector comes in, the whole thing will be high cost, low impact medical care rather than low cost, high impact medical care. Therefore, tertiary care, we already have a significant number of beds. We have to improve the infrastructure, and the costing is coming to doubling the current expenditure. Per bed at the district level, we are assuming 20 lakh rupees per year, roughly about 5,000 or 6,000 rupees per day. At the tertiary hospital and the teaching hospital, we are assuming 30 lakhs per year, assuming roughly about 8,000 to 10,000 rupees per day. These are not small sums, but these are not outrageous sums also. Well, for tertiary care, that kind of money is required. And we are coming to 60,000 crores for the teaching hospitals, 33,000 crores for the district hospitals. 50% of it is additional expenditure. Already half of it is being spent now, currently. It will be, the expenditure will be doubled. Next, last slide. The overall numbers. Go on, move on just. Move on. Move on. Move on. Okay, this is the overall number. The total expenditure of the public system in 2022, including all the committed programs, existing staff, etc., it's coming to about 4 lakh crores, 4.17 lakh crores. Today, expenditure of the government is 1.5 lakh crores, assuming 1.28% of the GDP is being spent. So in 2022, so 6 or 7 years down the line, this is the kind of money that's come to 1.73% of the then GDP. These are all nominal terms. Nominal GDP and nominal terms. None of this is at fixed costs. We're assuming, I've seen Dr. Mohan Guruswami's speech the other day, which was very surprising to me. The nominal growth last year was only 5% or 5.3%, etc. We didn't know that. So we were assuming normally 6-7% actual growth rate, 4-5% inflation. Therefore, about 11-12% nominal growth rate is what our assumption is. But if this 5% nominal growth rate is a persistent feature, then all these numbers have to be tossed out. We have a problem. I don't have an answer to that. On that basis, we assume our GDP, nominal GDP in 2022 will be something like from 130 lakh crores now, it will be 240 lakh crores, some 80%, 85% increase. And in that, it's coming to under 2% GDP, which is actually a very decent number. And as you've seen, we have made a very reasonably robust provision. These are not very conservative, very small numbers. Decent numbers are given in the Indian context. That's our belief. That's it.
Okay. I think also for ourselves, exciting and applause for all the presenters, because I think this is quite something. All right.